Gene-based interventions for myocilin-associated glaucoma, August 2026, first in human learnings, evidence reviewed through August 24, 2026. Introduction. Gene-based treatment for myocilin-associated glaucoma has moved from laboratory research into early human testing. The leading approach, called BD113, uses a virus-like particle to deliver a preassembled gene editing system into the eye. Its goal is to disrupt the harmful form of the MYOC gene in the trabecular meshwork, the drainage tissue responsible for removing fluid from the eye. The early news is encouraging, but extremely limited. A 2026 conference abstract reported sustained intraocular pressure reduction in one first-in-human participant without reported ocular or immune adverse events. A separate 2026 scientific review referred to 2 treated patients with normalized pressure and discontinuation of pressure-lowering medications. However, the full patient-level data, including exact pressure readings, duration of follow-up, visual field results, editing measurements, and statistical analysis, have not been publicly reported. APAO 2026 Abstract Book, Theranostics Review. This distinction matters. A promising first human signal is not the same as proof of safety or effectiveness. As of August 24, 2026, the official clinicaltrials.gov record still shows no posted study results and lists the trial's status as unknown, although its last known status was recruiting. The original estimated study completion date was December 2025. clinicaltrials.gov, NCT 6466537. Why MYOC is an attractive gene therapy target. The MYOC gene provides instructions for making myocilin, a protein found in the trabecular meshwork and other eye tissues. Certain harmful MYOC variants cause the protein to fold incorrectly. The abnormal protein can accumulate inside trabecular meshwork cells, trigger stress in the endoplasmic reticulum, damage the cells, and reduce aqueous fluid drainage. The result is often high intraocular pressure and progressive optic nerve damage. Myocilin misfolding in glaucoma, a 20-year update. CRISPR-Cas9-based treatment of myocilin-associated glaucoma, MYOC-related glaucoma, is commonly inherited in an autosomal dominant pattern. It can cause juvenile-onset open-angle glaucoma, often with very high pressure at a young age, or adult-onset primary open-angle glaucoma. MYOC variants are estimated to account for approximately 3% to 4% of primary open-angle glaucoma and around 10% of juvenile-onset open-angle glaucoma, although the percentage varies among populations and study groups. Medline Plus Genetics, MYOC 2026 Abstract Book. The therapeutic logic is unusual. Many gene therapies replace a missing or defective gene. In MYOC-associated glaucoma, the proposed treatment instead aims to remove or silence a toxic, overactive gene product. Laboratory and animal studies support this strategy. Disrupting mutant MYOC reduced abnormal protein accumulation, eased cellular stress, improved fluid outflow, lowered pressure, and preserved retinal ganglion cells in mouse models. CRISPR-Cas9-based treatment of myocilin-associated glaucoma. What was reported in humans by August 2026? BD13, the directly MYOC-targeted program BD113, is described in the clinical registry as an integration-defective lentiviral-derived virus-like particle carrying a guide ribonucleic acid and CRISPR-associated protein 9 as a preassembled ribonucleoprotein complex. The intended effect is to knock out or substantially reduce the harmful MYOC gene activity in trabecular meshwork cells. clinicaltrials.gov, NCT 0646537. The public human evidence can be summarized as follows. For the full table, please open this article on visualfieldtest.com. The most important limitation is that the public reports do not provide the information needed to judge treatment magnitude. The available material does not specify the patient's starting pressure, lowest pressure, pressure without medication, length of follow-up, number of glaucoma medicines before treatment, visual field status, or whether the treatment prevented progression. The review's reference to 2 patients also differs from the conference abstract's reference to 1 patient. This may reflect later enrollment or reporting, but that is an inference rather than a confirmed final dataset. APAO 2026 Abstract Book, Theranostics Review. What is known about the trial design? The registered study planned to enroll approximately 6 to 9 adults at Beijing Tongren Hospital in China. Participants were divided into 2 broad groups. People with a study eye that had little or no useful vision, intended to provide an additional safety margin. People with useful vision in the study eye and a blood-confirmed MYOC mutation. Each participant was scheduled to receive one intracameral injection in the study eye. The planned follow-up was at least 1 year. clinicaltrials.gov, NCTO 6465537. The main planned pressure outcomes were the proportion of participants with intraocular pressure of 21 millimeters of mercury or less, the proportion with at least a 20% pressure reduction from baseline, ocular adverse events such as inflammation, bleeding, infection, corneal reaction, or damage to the anterior segment. In participants with useful vision, changes in visual acuity, visual fields, and retinal nerve fiber layer measurements. The threshold of 21 millimeters of mercury is a trial measurement, not a universal treatment goal. A safe target pressure depends on the amount of optic nerve damage, the rate of progression, corneal thickness, age, and other factors. Delivery route and dose. Intracameral delivery BD113 is injected into the anterior chamber, the fluid-filled space between the cornea and iris. This is different from an intravitreal injection, which is placed farther back in the eye near the retina. The intracameral route is intended to expose the anterior segment and trabecular meshwork directly. In mouse experiments, the virus-like particle reportedly showed more selective delivery to the trabecular meshwork than conventional adeno-associated virus or lipid nanoparticles, which showed more dispersion toward the cornea. APAO 2026 Abstract Book. An intracameral injection is a familiar type of eye procedure, but it is not risk-free. Possible complications include temporary or persistent inflammation, bleeding in the anterior chamber, infection, corneal endothelial injury, pressure spikes or pressure that becomes too low, damage related to the injection itself. The study registry specifically lists endophthalmitis, hypopyon, hyphema, and corneal injection site reactions among the adverse events being monitored. clinicaltrials.gov, NCT 6465537. Single dose of 4 micrograms of P24 protein equivalent. The registered BD113 dose is 4 micrograms of P24 protein equivalent in a single intracameral injection. The P24 measurement reflects a viral particle manufacturing and quantity assay. It is not directly equivalent to the amount of CRISPR-associated protein 9, the number of guide molecules, or the amount of conventional viral vector genomes. clinicaltrials.gov, NCT 06465537. The publicly available trial information does not describe a conventional multi-level dose escalation table for BD113. Therefore, it is not yet possible to determine whether the reported pressure effect is dose-related or whether a lower dose might provide a better safety margin. Target engagement. What has and has not been shown? Target engagement means evidence that the treatment reached and changed the intended biological target. For a MYOC editing treatment, the strongest evidence would include editing of the MYOC gene in treated trabecular meshwork cells, lower levels of abnormal myocilin protein, reduced endoplasmic reticulum stress, improved aqueous fluid outflow, lower intraocular pressure, slower structural or functional glaucoma progression. Animal evidence. The BD113 abstract reported approximately 35% editing in cynomolgus macaques, even though the animals had pre-existing immunity against CRISPR-associated protein 9. This is important because it suggests that pre-existing immune recognition does not necessarily prevent editing. However, the result was reported in a conference abstract and does not substitute for human tissue evidence. APAO 2026 Abstract Book. Other recent preclinical approaches have produced measurable target engagement. A messenger ribonucleic acid lipid polymer system produced approximately 18% editing in a mouse study, reduced abnormal protein accumulation, and lowered pressure within several weeks. No obvious ocular inflammation was seen during the reported observation period. PubMed, Therapeutic Messenger Ribonucleic Acid Delivery of CRISPR-Associated Protein 9. A 2026 lipid nanoparticle base editing study reported approximately 17% editing, approximately 46% lower mutant myocilin protein, reduced cellular stress, and rescue of the glaucoma phenotype in mice, without detected ocular toxicity or off-target editing in the reported experiments. PubMed, lipid nanoparticle-mediated base editing. Human target engagement remains unconfirmed. The BD-113 clinical registry plans to measure P24 and CRISPR-associated protein 9 in aqueous humor and blood. These measurements can show exposure and distribution, but they do not by themselves prove that MYOC was edited. No publicly available human report by August 24, 2026 has provided a percentage of MYOC editing in a treated patient, mutant myocilin protein levels before and after treatment. Direct trabecular meshwork tissue analysis. Aqueous humor biomarker changes linked to editing, a validated relationship between editing level and pressure reduction. Thus, the reported human pressure response is a pharmacodynamic signal, but not yet definitive proof of human MYOC target engagement. Immunologic considerations. The eye has some immune protective features, but it is not completely isolated from the immune system. An intracameral product can drain through the eye's normal fluid pathways, enter the bloodstream in small amounts, and stimulate local or systemic immune responses. Pre-existing immunity to CRISPR-associated protein 9. Many people have already encountered the bacteria from which commonly used CRISPR-associated protein 9 enzymes are derived. In one human study, antibodies were detected against the Staphylococcus aureus form in 78% of donors and against the Streptococcus pyogenes form in 58%. T-cell responses were also common. Nature Medicine study indexed by PubMed. This immunity could theoretically reduce the amount of gene editing, cause inflammation inside the eye, affect the duration of CRISPR-associated protein 9 activity, make repeat treatment more difficult, produce systemic immune reactions. The monkey result is reassuring, but the human sample is too small to show how often pre-existing immunity affects outcomes. Vector and capsid immunity. BD-113 also contains a lentiviral-derived particle, including P24-related structural proteins. The trial plans to measure antibodies against P24 and CRISPR-associated protein 9 at 6 and 12 months. This is appropriate because immune reactions may appear after the initial injection rather than immediately. ClinicalTrials.gov, NC 06465537. For the separate GVB 2001 program, which uses a self-complementary adeno-associated virus serotype 2 vector, the study plans to monitor virus shedding in blood, urine, and tears, along with antibody, complement, and T-cell measurements. This program is not MYOC-specific, but illustrates the type of immune and biodistribution monitoring expected for ocular gene therapy. Clinical Trials, Gov, NCT 9217, Related Gene Therapy Programs. GVB 2001, a pathway-based not MYOC-correcting therapy. GVB 2001 delivers a dominant negative form of Roa to trabecular meshwork cells. The goal is to improve fluid outflow by altering a cellular pathway involved in drainage tissue function. It is therefore gene-based glaucoma treatment, but it does not directly repair or silence a MYOC mutation. The study uses a single intracameral injection of 25 microliters with low-dose and high-dose groups. It was listed as recruiting in May 2026, with an estimated primary completion date of December 30th, 2027. No human results were posted in the registry at that time. ClinicalTrials.gov, NCT 0697. Other MYOC approaches remain preclinical. Recent laboratory programs include viral silencing of MYOC, messenger ribonucleic acid delivery of gene editing tools, lipid nanoparticle base editing, earlier adenovirus-based MYOC disruption. These studies support several possible strategies: permanent gene disruption, temporary gene editing exposure, or mutation-specific correction. None should be presented as an available treatment for patients outside a properly regulated clinical trial. AAV-DJ-mediated MYOC silencing. Therapeutic messenger ribonucleic acid delivery. How gene editing compares with conventional treatment. Current glaucoma treatment is aimed at lowering intraocular pressure, not changing the inherited cause. The established options include pressure-lowering eye drops, laser trabeculoplasty, minimally invasive glaucoma surgery, trabeculectomy, glaucoma drainage devices, cyclodestructive procedures in selected advanced or refractory eyes. The American Academy of Ophthalmology describes pressure reduction as the proven treatment for primary open-angle glaucoma. Medication, laser therapy, and surgery each have established clinical experience, known complications, and rescue options if treatment is insufficient. American Academy of Ophthalmology, iWiki, primary open-angle glaucoma. National Institute for Health and Care Excellence Glaucoma Guideline. Potential advantages of gene-based treatment. A successful MYOC-directed treatment could potentially address an underlying disease mechanism, reduce dependence on daily eye drops, avoid repeated laser or surgical procedures, provide long-lasting pressure reduction after one treatment, be especially useful in selected people with early-onset, high-pressure disease. Important disadvantages and unknowns. Unlike eye drops, laser treatment, or surgery, genome editing may be irreversible at the level of individual cells. It could be difficult or impossible to undo if the edit is inaccurate. Other uncertainties include whether the treatment works for every harmful MYOC variant, whether enough trabecular meshwork cells are edited, whether the benefit lasts for decades, whether normal MYOS function is needed later in life, whether the treatment can be repeated, whether pressure can become dangerously low, whether it prevents visual field loss rather than simply lowering pressure. Most importantly, lowering pressure cannot reliably restore optic nerve tissue that has already been permanently lost. Gene therapy should therefore be viewed as a possible disease-modifying treatment, not a guaranteed method of restoring vision. For a patient with rapidly worsening glaucoma, very high pressure, or threatening visual field loss, conventional treatment should not be delayed while waiting for gene therapy development. Heritable counseling for families. A person with a confirmed pathogenic MYOC variant generally has a 50% chance of passing that variant to each child. The exact likelihood of developing glaucoma, the age at which it begins, and its severity vary by the specific variant, family, and other risk factors. Not every MYOC variant found on a genetic test is disease-causing, so laboratory classification and genetic counseling are important. Medline plus genetics, MYOC. Practical family steps. Families should consider confirming the exact genetic variant using a clinically validated laboratory, testing relatives for the known family variant rather than relying only on a broad glaucoma panel, arranging regular eye examinations for relatives who carry the variant, beginning surveillance early enough to detect high pressure or optic nerve damage before symptoms occur, discussing reproductive options with a certified genetic counselor, explaining that treating one person's eye does not remove the inherited risk for that person's children or siblings. A somatic eye injection is intended to treat cells in the treated eye. It does not change the inherited MYOC variant in the rest of the body and should not be considered germline treatment. Ethics and long-term risks, irreversibility and informed consent. Patients must understand that the intervention is experimental and that the gene edit may not be reversible. Consent should clearly explain the possibility of no pressure benefit, the possibility of needing medicines or surgery afterward, known and unknown eye risks, the possibility of delayed inflammation or other complications, the uncertainty about lifetime durability, the limits of available human data, the difference between research participation and established treatment. The first human participants should not be led to believe that pressure reduction proves the glaucoma has been cured. Off-target and unexpected editing. Gene editing systems can make unintended changes at other DNA locations or unexpected changes at the intended location. Even when an edit is directed at MYOC, researchers must evaluate unintended DNA changes, large deletions, rearrangements, editing of the normal MYOC copy, effects in non-target eye tissues, rare changes that could increase cellular growth. The short exposure time of a preassembled protein and guide complex may reduce prolonged activity, but any DNA change that does occur could remain long after the treatment particle disappears. Vector safety and delayed adverse events. The United States Food and Drug Administration recommends risk-based long-term follow-up for gene therapy products because delayed adverse events may occur months or years after treatment. For products related to lentiviral vectors, additional attention may be needed for replication-competent virus, vector persistence, clonal cell growth, and insertional mutagenesis. United States Food and Drug Administration, long-term follow-up after human gene therapy FDA guidance document. The fact that BD113 is described as integration defective is reassuring in principle, but the final safety assessment should still include detailed biodistribution, vector persistence, replication-competent virus, and long-term ocular surveillance data. Registries needed to track outcomes. A dedicated MYOC glaucoma gene therapy registry would be valuable because first-in-human trials will be too small to identify uncommon or delayed problems. The registry should record patient and genetic information exact MYOS variant using standardized genetic nomenclature, variant classification and testing laboratory, agent diagnosis, family history, ethnic and geographic background, baseline visual field and optic nerve status, other glaucoma genes or risk factors, treatment information, delivery route, injection volume vector or particle type, dose and manufacturing lot, guide sequence and editing system, use of immune-suppressing medicines, previous laser or glaucoma surgery, long-term outcomes, intraocular pressure, overtime, including diurnal variation, number of pressure-lowering medicines, need for repeat laser or surgery, visual field progression, retinal nerve fiber layer thickness, optic nerve imaging, visual acuity, corneal endothelial cell counts, inflammation, bleeding, infection, and pressure that becomes too low, antibody and cellular immune responses, vector shedding and systemic exposure, possible malignancy or abnormal cellular growth, patient-reported quality of life. The registry should include treated and untreated comparison groups when possible, publish negative results, protect patient privacy, and remain open to international participation. Long-term follow-up should continue well beyond the initial one-year trial period and should include the untreated fellow eye. Conclusion. As of August 24, 2026, BD1113 represents the most advanced publicly reported direct MYOC-targeted gene editing intervention for myocilin-associated glaucoma. The early human signal, pressure reduction without reported ocular or immune adverse events, is encouraging, but it is based on one clearly described participant and a secondary report referring to 2 patients. Exact pressure results, visual outcomes, durability, and human editing measurements remain unavailable. The strongest evidence for target engagement still comes from animal and laboratory studies. The clinical program's next priorities should be transparent reporting of patient-level pressure data, direct or surrogate evidence of MYOC editing, careful immune monitoring, long-term safety surveillance, and independent replication. For patients and families today, genetic counseling, regular optic nerve monitoring, pressure-lowering medication, laser treatment, and glaucoma surgery remain the established tools. Gene editing may eventually add a disease-modifying option, but it should not yet replace proven treatment or create false confidence that inherited glaucoma has been permanently cured. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.